Suba Dugumarsi. He's a professor of radiology, thoracic imaging and intervention, Massachusetts General Hospital, Harvard University. Dr. Magumarsi. Two principal areas of research are lung cancer and evaluation of new imaging techniques and modalities, such as the dual MRI CT and reconstruction algorithms. Dr. Matsuba also routinely performed percutaneous biopsy of the lung and chest wall. He is going to speak about lung cancer screening. So please, Dr. Su.
Thank you very much. I'm delighted to be here. I'm impressed with the hospitality, and I want to thank Dr. Bilal for taking this opportunity to organize at such a short notice. I'm really indeed very delighted. More importantly, I'm impressed with what I've seen and heard about Mansoura University, the so-called medical capital of Egypt. And I'm impressed with the services you provide and also the subspecialty organization of your department. It's indeed my pleasure to be here. I'm happy to share my experiences with you. Some of this may not be relevant, but I hope we can learn from each other. I'm very interested to know about the practice of radiology in your division. I'm very eager to listen to the other speakers who are going to be joining me in this session. Thank you very much. Lung cancer is a deadly disease. It causes over 150,000 deaths per year in the US. The 5-year survival of cancer is heavily dependent upon the stage of diagnosis. The stage 1 and 2 have much higher 5-year survival. When we go down to stage 3 and 4, the survival drops. The overall survival is only 19% because most of the cancers are diagnosed much later in stages 3 and 4. The most important paper regarding lung cancer screening came out in year 2011. This was in New England Journal of Medicine. This is the so-called NLST trial. The purpose of this trial was to see if doing a low-dose CT scanning would add any help or benefit to the patients who are at risk of developing cancer. As you know, the most important risk for developing cancer is history of cigarette smoking. So here they have divided people into two groups. The people who have smoked significantly, they were divided into two groups. One group followed with annual chest X-ray. The other group followed with low-dose lung cancer screening. So it was no surprise that low-dose lung cancer screening with CT had significantly better results. The overall improvement survival related to lung cancer was more than 20%. Not only that, there was also reduction in all-cause mortality. That is, death from causes other than lung cancer was around 7%. So this was such an impressive result. The study had to be concluded much earlier. Since then, it has been recognized that low-dose CT scan screening for high-risk population does indeed offer significant benefits and reduction in mortality. So I'm going to show you a number of trials. I'm not going to go into details, but after the NLST trial, several other trials have been going on. I want to touch upon one other trial, Nelson trial, because the results of this are already published. But besides that, there are several other trials, like Italian lung study, UK lung cancer screening study, and also Dante screening program, among others. So one thing I want to talk about is Nelson, because when you're adopting a technology such as low-dose screening, which involves a lot of resources, which adds to the healthcare cost, it is important to have multiple studies that prove the efficacy of low-dose lung cancer screening. So I want to touch upon this Nelson trial, which was done mostly in Belgium and the Scandinavian countries. This study also has shown significant decrease in lung cancer mortality. The reduction was more prominently seen in women. The reduction in women was around 61% in terms of mortality. In men was 26%. This is much better than what was found in our trial, NLST trial, where reduction in mortality was around 20%. There is also some other differences. NLST trial focused on annual screening, whereas Nelson trial had a different screening interval. They started off with 1 year, then after 2 years later, then a gap of 2.5 years. So the participants were slightly fewer in Nelson trial, but it is important to note that the entry level for smoking history was much lower. For an LSD, the smoking in terms of back years was 30 years, whereas for Nelson it was only just over 50 years. So this is an important difference, but still a very good significant reduction in mortality was observed in this trial. So who are the patients who are enrolled into the trial or into the screening program? So anybody between ages 15 to 18, the patient at the time of entry to the screening should be asymptomatic. They should have at least smoked for 25 years, and the patient should be a current smoker or should not have quit the smoking in the last 15 years. When you are performing lung cancer screening, it's an agreement between the patient and the provider. The patient should follow few rules, and the provider should enter into an agreement with the patient so that we do the maximum service to the patients and the patient derive the maximum benefit of the screening program. So there are few patients who become ineligible for a period of screening even after their enrollment. For example, if somebody has stopped smoking for more than 15 years, they are no more eligible for lung cancer screening. If the patient has substantial health problems that would affect their longevity, the patients are not eligible for lung cancer screening. Similarly, the patient loses interest and does not want to undergo definitive curative therapies for lung cancer, the patients are no more eligible for lung cancer screening. It is also important to understand that the technique we follow for lung cancer screening is different. This is a low-dose screening, and there are specific criteria which are to be adopted. The radiation dose is very important. The CTDI volume should be less than 3 milligray, and the reporting should be standardized. The patients who are undergoing this screening, then anywhere in the US, have the same reporting format, what we call as lung rats. Then, as part of the screening program, they are also counseled for smoking cessation, and all the data which is acquired through the lung cancer screening program is collected and maintained in a national registry that is organized by the American College of Radiology. To implement a successful lung cancer screening, there are a number of steps. The first thing is to already talk about the eligibility, the education of the patients, and how to order the exams, and how to acquire the study. These are all important. I'll talk about a few things here. The first is image acquisition, image review, and how to improve the quality of lung cancer screening. So we talked about listing a low-dose CT scan. So we have to be very mindful of the radiation dose, and we should take steps to reduce the radiation risk. So the CTDI volume is the average dose of radiation that is in each slice. Then if you multiply this CTDI volume over the scan length, you get what is called as DLP, or dose length product. And dose length product is multiplied by a factor to give you the effective dose that is measured in millisieverts. The effective dose in our instance for the chest is organ specific. The multiplying factor is 0.14. So there are certain guidelines. We cannot exceed CTDI volume of more than 3 milligray, and there is an association called as American Association of Medical Physicists. They are developed protocols, and if you follow these protocols, you can significantly reduce the effective radiation dose, and you can keep the radiation dose much under 1 millisievert. So this is a significantly low dose, even less than what is recommended by the NCCN. According to NCCN guidelines, we can go up to 5 millisieverts, but if you follow the recommendations proposed by American Association of Medical Physicists, we are able to achieve a much lower radiation dose. So the way to control the radiation dose is to focus on the tube current. The best is to use automatic MA modulation. If that is not available on your scanner, we can do a low fixed MAS, which is the second best option. And we want to keep this as low as possible. If you do not have highly sophisticated things like automatic MA modulation, we may try to get less than 5 millimeters. the tube current should be low. This is not only true for the lung cancer screening, but even for repeat lung nodule follow-up, we tend to do low-dose CT scans. For lung cancer screening, it's always a emitter or spiral mode. We want to use high pitch if motion is going to be a factor in acquiring the images. The rotation speed should be fast. If again the patient, if you are worried about patient's motion, and detector concentration is usually wide. So when you reconstruct the images, we used to do what is called as printed back position, but now most of the scanners are dedicated to reconstruction technologies. So this goes with several names for it can be ASER for GE scanners, it could be Sapphire for Siemens scanners. But more recently, there is also a significant improvement in our iterative reconstruction technology. So now we are in the era of artificial intelligence. We also have deep learning technology or reconstruction techniques. These are right now available on few scanners, but in the future, it will be more widely available, and the cost will also come down. So if you're interested, the AIPM protocols are widely available online. You can search them online, and you can suit them or adapt them to your model. Suppose you have Siemens, you can choose the guidelines recommended by this association. If a Philips scanner, you can use the Philips scanner. I see that your hospital has Philips scanners, so you can use these protocols which are available, developed by this association to reduce your radiation dose while acquiring the images. When you do a lung cancer screening, you start from the lung apex, you go to the lung basis. You do not have to include the adrenal glands, and the patient should be holding the breath and full inspiration, but in not possible, still the patient should hold the breath at a mid-inspiration so that you can get images without respiratory motion artifacts. So I want to spend a couple of minutes talking about the lung rags. I said when you're reporting lung cancer screening studies, you have to follow a particular standardized method of reporting. This reporting is called as lung rags. The lung rags, the rags in the lung rags stands for reporting in data system. If you are aware of this rag system elsewhere in the body, for example, for the mammogram we have rags, for the liver we have L rags, for prostates we have T rags. So this is a standardized reporting. It is particularly useful when you are following patients for screening. So here on this lung rags, if you see here, you see in the colored boxes, there are numbers going from 0 to 4x. So 0 is for whatever reason we cannot even interpret the stage. But as the number increases from 1 to 4, the risk or probability of the cancer for a given finding increases. Say for example, somebody has a category 2 nodule. If you see from second to last, the risk of cancer is less than 1%. But as you go down, if the category is lung rags 4X and 4E, the risk of cancer is over 15%. So as the number increases, the probability or predictability of the cancer increases. So as you can understand, if somebody carries a lung rag score of 2, the patient needs only an annual screening. Whereas somebody comes out with a lung rag score of 4B or 4X, the risk of cancer is much higher. So these patients cannot wait for 1 year. These patients need a much shorter interval follow-up imaging, intervention, or a subspecialty consultation. Say in our hospital, if somebody carries a diagnosis of a score of 4X, we refer them to a multi-specialty clinic where a surgeon, medical oncologist, radiation oncologist will look at the scans, have a meeting with the patient to figure out what is the best way to approach this patient. To show you some examples, we know that lung nodules come in several densities. Body is can be divided into solid nodules and subsolid nodules. And subsolid nodules are again divided into pure ground glass and fast solid nodules. So most of the guidelines which are established for this lung rags screening are specific for solid nodules and subsolid nodules. Say for example, somebody has got a pure ground glass nodule. For the beginners, a ground glass nodule is a nodule in which you can see the blood vessels of the lung parenchyma. If you can see through that, it's like a little hazy density in the lung. This is a ground glass nodule. So these are also can be cancers, but they tend to be more indolent cancers, or they take longer time to become clinically active or aggressive cancers. So a cancer like this, though it looks very big, because it is so ground glass, it can be followed at much longer intervals. So usually, typically, we try to follow them in 1 week. So it may look counterintuitive to think that something looks so big, but because the density is of ground glass, the probability of becoming an active cancer is much lower. So we tend to follow at much longer intervals. So I've shown you two different versions because as we're doing lung cancer screening, we are also evolving. Before we used to call them as Langaraj 3. We used to do 6 months follow-up. But after initial review of the data we collected, we realized that these cancers need to be very indolent. Therefore, we don't have to do in 6 months follow-up, but we tend to do 1 year. So if it's Langaraj category 2, the follow-up is 1 year. So other hand, this is a nodule where it has ground glass component, very hazy, but in the center of this one there is also a solid clumps. This type of nodule is called as part solid nodule. Nodules of this configuration tend to be at much higher risk for being a lung cancer, or more importantly, these can be invasive lung adenocarcinomas. Therefore, we tend to follow them at much closer intervals. So here, as you see, from 2018 April to May 2019, roughly 1 year, plus or minus 1 month. The solid component is getting larger. So this becomes more concerning for invasive lung adenocarcinoma. At this time, it is important to intervene. The patient should be evaluated by a multidisciplinary clinic, and we should figure out how best to deal with this lung nodule, which is most likely a lung cancer. So there is the other nodule here. Again, this is a part solid nodule because the lung has got, this nodule has got a lot of ground glass density and also more solid component. This is ground glass because you can see the blood vessels forcing through the nodule. So this one, because the solid component is around 1 centimeter, this becomes a much higher risk for an aggressive cancer. We call this as 4B. At this time, the options are either this patient gets a biopsy or gets further investigation with a PET imaging. As you can see here, this is a PG app. So a nodule which has characteristics of a lung cancer or CT scan, and on top of that, it also has high APG activity. This is very concerning for being a invasive adenocarcinoma, and therefore this one has to come out or should undergo some curative procedure. So this is another example. Here the nodule itself is not very big, very small nodule in October of 2016. Roughly 13 months later, this nodule has increased in size. But here the nodule size itself is not that concerning. But because it has increased in the interval increase in size becomes a significant factor, and therefore the risk of cancer is much higher in this particular nodule. So we follow this after 3 more months. At this time, I decided a 3 more month follow-up because we were not sure if this is really a cancer or it could be some inflammatory process which is developing around the pre-existing nodule. So we did a short interval follow-up imaging and we definitely even further. So now it is very convincing that it is a lung cancer, and still it is a small nodule, less than a centimeter. So it is a much early stage cancer. So this has to come out. And as you can see here, this nodule was also a PGRA. Once you think a nodule is cancer, it is important to do a PET imaging to stage this cancer properly. More importantly, look for high-level survival mutations. So sometimes it is not uncommon to see a nodule which is a cancer. For example, here, this particular scan in December 2016, there was no nodule, but roughly this is around 14 months later. This one has got a speculated nodule. Very naturally, nodule looks like a cancer. But because it is totally new, at this time we are not sure if it's a cancer because it is not uncommon to find infection and inflammatory nodules which can look like cancers. I believe there is a talk which is a limits of cancer which is somewhere in this session today. So you can see and learn a lot about these nodules. which look like cancers, but they're not really cancers. Therefore, if you see a nodule for the very first time, it is important to make sure that this is not an inflammatory nodule or a nodule related to infection. What we do is we do a short interval follow-up imaging. Here, I scan after 2 months, the nodule has completely returned. So we know that it's an inflammatory nodule. So we should not be hasty in acting upon nodules, even though they look suspicious for being cancers, if this is the very first time you're noting this nodule. So the quality improvement aspect of the lung cancer screening is very critical. We have to be mindful of the radiation dose, and we should also be mindful of the interventions we are performing on these cancer screening patients. Because these patients are asymptomatic, they are looking for cancer. You do not want to do too many interventions and cause more complications, increase the morbidity. It is important to make sure that you understand when to intervene, and even when you are performing interventions, you keep the complications at a very minimum. So this was the whole background of lung grafts. So this was the trials have shown very impressive results. It was an NLSD, Nelson trial, and several other trials in Europe have demonstrated the value of this lung cancer screening. But the problem is what works in a clinical trial may not have achieved the same benefits when implemented in clinical practice. Because all said and done, a clinical trial is a controlled environment. You follow these patients very carefully. We are very, very careful of the criteria. But what happens when you roll out into clinical practice? So this is something which we are worried about. So this is a study done by me and my colleagues. Zhang was a fellow with us. We looked at the data for the last 5 years in our hospital. We looked at over 4,000 subjects who underwent lung cancer screening. We wanted to know how is this translating into clinical practice. So the results were very interesting for different reasons. One, it was better than it was anticipated or expected. For example, the cancer detection rate in our study was 3.8%. This was only 2.4% in national lung cancer screening trial. That's the first thing. So we are seeing more cancers. Secondly, the cancers we are picking up were much earlier cancers. As you know, stage 1 cancers tend to have much higher cure rates, and the 5-year survival rate is much higher compared to the advanced cancers. So not only you are picking up cancers, but you are picking up cancers at a much earlier stage. Therefore, you are offering more benefit to these patients. And the mortality from the lung cancer, because I told you, even though when we diagnose cancer, it doesn't mean that the patients will not die. Some patients will still die, either because of the cancer or for some other reasons, as a part of the workup complication during the procedure. The mortality in our group was 0.45 compared to 1.33 in NLSD. So our results have shown that if properly done in clinical practice, the results are much better than NLSD trial. So we also looked into the high-risk nodules like lung grafts category 3 and 4. We know that these nodules are tend to be aggressive cancers. So we looked into our own literature, and it is also very impressive. The risk of cancer for lung grafts 4X was 76%, more than that. And for lung grafts category 14 was 36%. So not only that you are picking up cancers at a much higher rate, but you are also the incidence of cancers or prevalence of cancers for category 3 and 4 nodules was also much higher than was anticipated by lung grafts lexicon. So we also run into some problems. We started noticing that many patients when undergo lung cancer screening tend to have this inflammatory nodules, Greenberg nodules, bronchiolitis, ground glass opacities. Because these patients are heavy smokers, they have COPD, they have a lot of endobronchial mucus, they tend to have these infections, and they may be asymptomatic from infections. When we screen them, we do not realize that they are having infections. But when we get the scans, we realize that this looks like infection. So we were struggling with how to deal with these patients who have what we consider to be infection. If you apply a lung grafts category, it looks like the size is so big, therefore they fall into high risk for cancer. But we know that this is not how cancers look, this is more a picture for infection. So we wanted to know how to deal with these forms. So we did our analysis, and we found that most of the nodules are Greenberg configurations, consolidations. They are just pneumonias. We don't have to assign any lung category to this particular type of nodules. So then the other thing is, when you're looking for lung cancer, you're not just imaging the lungs, you're also imaging the other body parts. You're imaging the chest wall, you're looking at the median spinal, upper abdomen. And you tend to pick up incidental findings in this particular organs. We have seen breast cancers, we have seen renal cancers, RCCs, we have seen even pancreatic cancers. So this is something we should be mindful of. Though your quality is not great for assessment of abdominal viscera, still you can make out all these structures and we can pick up any cancers. The incidence of extrapulmonary cancers in our study was around less than 0.5%, and there are other studies out there. Good studies from Italy also shown the extrapulmonary malignancies are on the same range. So be mindful of other organs and other potential cancers that may be seen as part of your lung cancer screening. The other thing which is important is you're also looking at the heart. If somebody has got heavy coronary artery calcium, we know that there is a correlation between the cardiovascular events in this particular group of patients. So when you see heavy coronary artery calcifications, please be mindful of that. These findings can be reported under what is called as S findings or a significant findings. So this patient has got a lung nodule which gets a lung gas category either 2, 3, 4 or whatever it is. But you can also put an S by the side of that one. The S stands for a significant finding. The significant finding could be significant coronary artery calcification, could be aortic aneurysm, could be a breast mass, kidney mass. You also document them. Because the advantage of lung cancer screening is you are not only reducing the lung cancer specific mortality, but you are also reducing the all-cause mortality. You are also reducing preventing deaths from causes other than lung cancer. So this is an added benefit. So you have to pay attention to these things. So there are a number of problems in lung cancer screening. Nothing is without the problems. The first thing is you may not pick up all the nodules. There will be some nodules which are cancers which can be missed. They can be interval cancers. Then for a given nodule, because of lack of experience, we may assign it incorrect designation of lung RAS category. And there are a number of tools, a number of algorithms to manage nodules. We have Fleischner guidelines and other stuff. But when you're doing lung cancer screening, we are bound only by lung RAS lexicon. We should not be using Fleischner guidelines for nodules which put on lung cancer screening. This is something we should do. So finally, now in this current era, we are not just doing lung cancer screening. There are a number of trials going on right now. They are collecting blood samples and the patients are coming for lung cancer screening. So at this time, what they do is they look for some biomarkers in the blood. I'll be talking about this in the future of lung cancer diagnosis. We look at some products in the blood. They can be either tumor cells or tumor degradation products such as DNA fragments, RNA fragments. When you take this information along with the findings in the CAT scan, your prediction of cancer is much better or much higher. So this is going to be the future. In future, you're not just doing imaging. It may be true for other screening tests also, like for mammogram, for screening for colonoscopy, or for prostate screening. We combine these imaging features with some other biomarkers to improve our accuracy of predicting lung cancer. So finally, when you have this data, you collect all this data, you have to export it to the national registry, so we understand how we are tracking these nodules. When you export it to the National Cancer Registry, you have to talk about the scan, what type of scan was done, how much was the radiation dose, what type of nodules were detected, and what was the outcome of these nodules. And if this intervention was performed, what was the complication rate for this intervention. Because when you're doing the screening patients, you're doing this test on somebody who is healthy, walkie-talkie patient. By doing this test, we should not be causing more harm to these patients. So this is something we should be mindful about, and we keep track of all these details. So finally, we upload this data into the national registry. So, and I'm sure we'll get a result after a few years about the success of lung cancer screening in the US. So there are a lot of future opportunities. We can develop more software. We can implement a lot of artificial intelligence tools. And we can involve more patients. Some patients who are underprivileged may not be enrolled into the lung cancer screening program. So it's a great opportunity for providers to have a discussion with the patients to encourage them
to get into lung cancer screening program. And it's also an opportunity for us to counsel them for smoking cessation. So these are some of the future directions of lung cancer screening. I want to thank my colleagues. Please ask any questions with this sometime.